Hey everyone, welcome to a special episode of Why Should I Trust You? So, today we want to dig into the news about the CDC recommending a reduced number of vaccines in the childhood immunization schedule. It's a big deal, one of Kennedy's biggest moves yet, and we think it's worth its own episode. It's getting a lot of reaction. We, as always, want to understand why this is happening, what the rationale is for doing it, and what the consequences could be for all of us. And yeah, ultimately, could this help or hurt our efforts to rebuild trust in this country? The other thing we want to hone in on is the fact that the administrations base this change on how other countries handle their childhood vaccines. They say most of our peer countries recommend fewer vaccines than we do, and they have good outcomes. They keep bringing up one country in particular, Denmark. So we invited two doctors from Denmark, well versed in their vaccine policy and practice, to join us. And joining them will be a friend of our pod, epidemiologist and physician Dr. Michael Mina. On this episode, we want to know, is Denmark, which is a much smaller country with universal health care, is it really a good model for America's vaccine policy? And was this change actually grounded in gold standard science, the standard that's so important to Kennedy and to Maha? And after listening to what mainstream public health experts are saying, is it really the case that this change increases the risk for American children, especially given all the vaccines will still be available and covered? And can we learn nothing from countries like Denmark that, it's true, recommends fewer vaccines? Fair warning, this could get uncomfortable, but look, it's season 2. Let's get to it. Hey, welcome everyone. Do you like our new music? New music?
We're liking it. We're liking it.
Right?
I was
I
jamming.
love it so much, B.
I missed my exit.
Okay, well, listen, this new year was young when the news broke that the CDC was rolling out these big changes to the childhood vaccine schedule, with Denmark emerging as our North Star of sorts. Denmark and other wealthy nations that do not recommend as many vaccines as we do. We're going to dig into all that, and we're going to be joined by Dr. Michael Mina, a friend of the show, along with some public health experts from Denmark. But first, who are we? I'm Brenda Adhikari.
I'm Tom Johnson.
I'm Maggie Bartlett.
And I'm Dr. Mark.
Yeah, as you know, Brenda and I are journalists. Mark's a medical reporter and a physician, and Maggie's a virologist. Just a big reminder, you can send us notes, compliments, complaints, story ideas, all to questions@whyshoulditrustyou.net. Also, check out our Why Should I Trust You Substack page, and you can subscribe for a weekly look ahead that we're putting together there.
Yep, lots of good stuff in there. But look, today we are tackling a huge story. We're going to try to do our best to cut through all the noise. There's a lot of big feelings around this story out there. And we're going to get at what's going on here with the change in our childhood vaccine recommendations. And we've got some terrific guests on board to help us do that. They are actually standing by. They are listening to us as we speak. So what we want to do first, though, before we get to them, is we want to walk through a few important facts just to give us some context to set us up. So tell us what we need to know, Tom.
Yeah, so let's briefly go back to September. That's when President Trump spoke at the White House about Tylenol and pregnant women. You remember this press conference that he held? In the process, he riffed on how many vaccines American children are given. That was the way he looked at it. And he said, quote, "They pump so much stuff into those beautiful little babies, it's a disgrace." So that was September. And then if we flash forward to December 5th, the president issued a memorandum directing HHS to review, quote, best practices of peer developed countries. And they specifically cited Denmark. And the memo called on HHS to review the scientific evidence that informs those best practices, and then to align America with our peers if what they were doing was better than what we were doing. So HHS took the ball and ran with it, and it resulted in the change that was just announced a week ago. And obviously the big headline was that the number of vaccines recommended for all American children went from 17 down to 11. And just remember that they had already changed the guidance around COVID vaccines, saying not all kids should get it. It should be a conversation with your doctor. So let's take the 11 core vaccines in which there is no change. Those 11 are diphtheria, tetanus, pertussis, Haemophilus influenza type B, pneumococcal disease, polio, measles, mumps, rubella, and HBV, as well as varicella or chickenpox. So there's no change in those vaccines. That means we're really talking about 6 vaccines for 6 important diseases: hepatitis A, hepatitis B, flu, some forms of meningitis, RSV, rotavirus. These are the ones where there's a change. And the CDC says there's now two pathways. For children with clear risk factors, they should get these vaccines, while for other children, parents should get with their doctor to decide what's best on their child's individual circumstances. Does it make sense for that child to get it? It will no longer just be a routine recommendation for all children. And the CDC calls this second approach shared clinical decision making. HHS said that they made this list after consulting with 20 of our peer nations. And they basically consulted with those nations and asked, which vaccines do you recommend? How many do you recommend in total? And what are your results? Secretary Kennedy put out a statement saying, after an exhaustive review of the evidence, we are aligning the U.S. childhood vaccine schedule with international consensus while strengthening transparency and informed consent. This decision protects children, respects family, and rebuilds trust in public health.
Yeah, Tom, that was one take. And then the other take is the responses from the physician groups to the federal announcement. And believe me, they didn't mince words. So after this announcement, the president of the American Academy of Pediatrics said, quote, "At a time when parents, pediatricians, and the public are looking for clear guidance and accurate information, this ill-considered decision will sow further chaos and confusion and erode confidence in immunizations." He went on to say, "This is no way to make our country healthier." And then the chair of the American Academy of Pediatrics Committee on Infectious Diseases said, quote, "Unfortunately, our government is making it much harder for pediatricians to do our jobs, and they're making it much harder for parents to know what to do." To say it's all dizzying is just an understatement. But for parents who are really concerned about their visits going to the pediatricians right now, it is important to mention that for these 6 vaccines that we just talked about where the changes are happening, which again, as of this week, are no longer recommended for all American kids, they'll actually, for now, still be available to all kids. So right there already, I've just confused you. I just told you they're not recommended for all kids, but they're still available for all kids. So HHS stresses, and every single time they're talking about this, they bring this point up that, at just about every chance they get, they say, if you want your kid to get vaccinated, they can still get the vaccine. So for now, the 6 vaccines will still be covered by insurance. Although their legal experts are telling us there is wiggle room on this, and it's still early, so we're not sure. For now, they'll still be covered by Medicaid and will still be made available through the government's program that provides free vaccines to children. And finally, according to experts, it appears, and emphasis on appears, that these 6 will still fall under America's vaccine liability shields. Remember, that's that shield that we've talked about on the show that protects vaccine manufacturers from being sued. But it's early, and this is still certainly open to interpretation.
Yeah, so what does Denmark have to do with it? So it was cited in the HHS assessment that was put together that led to this decision. And it was cited right out of the gate by the president's memo back in December as a model, one of these peer nations that we should be looking closely at to see how they're doing it. And just briefly, just hitting on some of the highlights of Denmark as it relates to this conversation. Obviously, this is a country that is extremely different from America. Denmark has 6 million people. America has 343 million people. Denmark has one of the most generous parental leave programs in the world, which, that means, and we'll talk to our experts about that, but, that means that newborns are likely to spend more time at home in the beginning of their lives rather than at daycare. And of course, the biggie, Denmark has universal health care. America obviously does not. So in Denmark, parents have fewer constraints to go see a doctor. And critically for us, compared to the 17 vaccines America recommended for all kids before the change, Denmark recommends 10.
Yeah, Tom, and I just want to underscore as the virologist in the room that different countries are exposed to different pathogens at different levels. And so saying we're going to take one country and compare it to another, really, you have to think about what pathogens are prevalent and transmit in different periods. HHS Deputy Secretary Jim O'Neill said that the change to our vaccine schedule was based on, quote, a scientific, evidence-based, data-driven response to the president's directive, unquote. And public health veterans disagreed, like Mark was saying. They say the changes were the work of top political appointees and not the CDC's Advisory Committee on Immunization Practices, who were not consulted, and that this was done without any public deliberation, which truly is a complete departure of what was done previously.
Okay, so we're going to digest on that for a second, and in a moment, we're going to bring in our guest to get the perspective on this change for our vaccine schedule. We will be right back. Okay, welcome back, everyone. Really excited to get into this. Joining us now is Dr. Michael Mina. As you know him, he is a friend of the show. Michael is an epidemiologist, an immunologist, and a physician. Over the course of his career, he's been an associate professor at Harvard Medical School, as well as the T.H. Chan School of Public Health. At the height of the pandemic, he led America's Test to Treat program, which connected home testing to treatment options. And he's also been a scientific advisor for health startups. Welcome back, Mike.
Well, thank you so much. Very happy to be back.
And joining us is Dr. Eskild Petersen, an infectious disease specialist from Denmark, who's been spending 14 years working there at the National Public Health Institute in Denmark before returning to clinical work. He's now an adjunct professor and a leading expert who writes books and edits an international journal on infectious diseases. And importantly, he has worked on Denmark's vaccine policy. Welcome to the show, Eskild.
Thank you.
And Dr. Lona Graf Stensbella. Lona is a pediatrician who has spent more than 20 years caring for children with infectious diseases at Denmark's National University Hospital. She's also a professor, the longtime chair of Denmark's Research Ethics Committee, and she says she's a proud mom of 5. Amazing. Welcome to Why Should I Trust You? Now, we're going to get to the Danish schedule and how you all handle things over there in a minute. But Mike, I first want to get your reaction to the new schedule right here in America. What went through your mind when you heard it?
I think the biggest thing that went through my mind was the first thing was they didn't unrecommend, everything. That was like, that at least was good. Like MMR, so some of these core vaccines that, frankly, RFK Jr. has spent over a decade now trying to undermine. No, those weren't touched yet. So that's good. The second piece that went through my mind is that there was just a blatant disregard and frank destruction of the purpose of ACIP. So we spent all of the last few months with the ACIP committee in kind of like the front page of the news in America around the hepatitis B vaccine and about changes that this administration might make. At a minimum, for the hepatitis B decision that was made at the end of last year, at least they held the ACIP meeting. They decided then to kind of undermine that whole process that they themselves did put together, as flimsy and kind of fumbly as it was. They undermined the entire, everything that they were saying when they then went and decided to make a much more sweeping change without ACIP and without any modicum of sort of like a transparent US-based decision making. And so those were kind of the two biggest things. I had heard a little bit before the announcement through various channels that there was going to be a big announcement, a big change. I was assuming everything was going to get kind of shifted. So I was glad to see that not everything did. And I was, unfortunately, disheartened to see this complete blatant disregard for a system that, as many problems as it might have, still works and has worked very well. And to see it just be completely decimated in its omission of being part of this process is pretty startling, and it should make everyone nervous, not about vaccines, but about what this administration is sort of willing to just disregard in terms of lawful structures that we actually have in the United States that are just being completely disregarded all over the place.
Mike, you talked about the operational and logistical issues or just kind of takeaways that you have with the announcement. Can you give us a sense about the medical side as a physician? What do you think about the health side of this?
I think the basic premise of moving some vaccines or even all vaccines into like the word shared decision making, vaccines have always sort of already been shared decision making. We don't tie kids down and say you must be vaccinated or you can't leave this physician's office. So in some ways, there's always been shared decision making. Parents have always been allowed to decline a vaccine, which is what we've been seeing. So from that perspective, I think it's a little bit more about the communication and the optics. Like, I'm actually very much okay with vaccines being shared decision making, because if they work and if our pediatricians are well educated, then that's actually the most important thing for pediatricians to say, this vaccine, if we know it's unequivocally good for you, then it should be recommended for all kids by their pediatricians. And it's the pediatricians' offices that are already doing it. So that part doesn't on its own bother me so much. But what is challenging is that it wasn't done in a phased approach. So it's confusing in that sense. Because we've had this long history of vaccines being either universally recommended or having some be recommended based on risk, that the ones based on risk generally have required physicians to really understand those vaccines a little bit more. And pediatricians have generally been able to kind of take a seat back and not really know much about the vaccines that they're giving because the CDC recommendations have been so strong that they've been allowed to like not really understand vaccine immunology and things like this. You might hope that pediatricians do, but let's be honest, like most people, including doctors, don't fully understand the data behind vaccines. And that was okay. So to just have this like rapid break from that without a phased approach, without continuing medical education to make sure that pediatricians have the right information, I think that's where like the medical risk really comes in, because just shared decision making alone should not be a four-letter word in public health. Like, I hate that it has become that. People are saying shared decision making is like an awful thing and it's an anti-vaccine term almost now. We shouldn't have gotten to this point. But unfortunately, this administration and making these sweeping changes without any sort of plan have kind of put us in this position because, like, the critics of it, which I am critical of it, would say that this is going to lead to a lot of kids not getting vaccinated. In pretty short order, we're going to see a pretty rapid shift in just what schedules pediatricians are looking at. They'll start looking at AAP instead of CDC's website, and hopefully it will keep things on the rails.
I want to bring in our friends from Denmark. I want to understand a little better. We keep talking and looking at your country as this model, but how does Denmark approach vaccines?
I would say that it is a process where we try to involve stakeholders like the different kind of societies, ID, public health, pediatrician. There's a thorough evaluation by the authorities about what can we save in terms of perhaps mortality, but also morbidity, hospital admissions. And then in the end, it move up to the governments who have to allocate a budget because the childhood vaccinations is actually free. One of the things I have noticed over my years, the last 30 years, is that we are looking very heavily on the number of injections we give to the children. And we have been following the MMR adherence over the past years, and it just a little bit above, a little bit below 90%. And there's been a discussion, if we have too many jabs, then the adherence will drop. So the total number of jabs is also important. But I think the important thing that I really want to stress is the long process with a discussion between different stakeholders and a political backup, but also discussion in the press.
Do you think America gives too many shots, too many jabs, as you said? And if you think that, do you think it's dangerous for the health of children to have that many shots? Or do you think it erodes people's trust in the system to get vaccines in general?
Well, we have decided not to recommend influenza and COVID vaccines to children and young adults, not because we think it's the shots are dangerous. Absolutely not. I mean, everything has side effects, but very rare and not very serious. So it's simply about that. If we recommend influenza and COVID, which is not recognized in the population as a serious problem for children and young adults, then it will be an extra jab and it will decrease the overall adherence to the program. Lone, what do you think? Am I right?
Yeah, I think you're right. I would like to actually take a step back and then comment on something that Michael said, because if you want high adherence, a high uptake here, you need to make these things simple. And now you're making things, I think, very complicated to the American society, both to the pediatricians and also to the parents. A lot of insecurity, probably more skepticism regarding vaccines is the most probable result of that. So,
but are you saying that our change is making things not simple?
I think the change is making things not simple. And that is because of what Michael mentioned, the shared decision making. It was always a shared decision making, but now it's a difficult, a complicated shared decision making. Even just to see at the schedule on the CDC homepage these days is quite complicated to find out what is actually meant. Before you had like one table, now you have free tables. It's just much more difficult for both the parents and also the pediatricians.
Before this change, what did you think of the US vaccine schedule?
I think it was like having maybe a bit too many vaccines. But I think it's in Denmark we are very privileged. We live in a very affluent, very well educated, very digitized society with free access to public health care. And that means Denmark is a low risk for severe infection society.
Because people can go to the hospital, people can go to the doctor without giving it a second thought, right? Is that the difference?
Yeah.
I think that's lost here in this conversation.
But I think that's very, very important because one of the most strong determinants of severe infection, a very strong determinant is if the child is chronically ill in some way. But besides, the strong determinant of severe infection is socioeconomical status. And so the people who need the vaccine the most are always the one who get less vaccines. And now in Denmark, a smaller proportion of the population has low socioeconomy. And I think that proportion may be larger in the United States. And it's so if you get a severe infection in Denmark and you may have very low socioeconomy, then you go straight away with your child to the doctor, to the hospital, receive any kind of care for free because it's tax paid in Denmark. I think this means that people, they go immediately to the doctor, to the hospital. They don't have any reason to wait. And if you catch the child and the infection in the initial stages, it's much, much easier to treat the patient. Yeah, so I think it's a difference between determinants of severe infections are not equally distributed between the United States and Denmark. We must talk about that.
And that's why I think one of the reasons why we are not including rotavirus in our schedule, because we do not have any mortality from rotavirus. There are some hospital admissions, but not. But also, one of the last vaccines we introduced was RSV, but we are not using monoclonals at birth. We immunize pregnant women in the third trimester, and then they will pass passive immunity to the newborn. And that's also a matter of cost. It's much cheaper to immunize the woman, and the mortality and hospital admissions from RSV is below the age of 6 months.
Yeah. And also what you talked about before, Eskil, that because we are so privileged in Denmark and we have such a low mortality, so also for RS virus, we don't see mortality. So then we don't like the jabs. Then we start to consider number of jabs because we are so privileged. And we don't really have to convince the parents because we don't have the risk of death. At least, of course, we see severe infections, but I think that's maybe lost in the discussion here. It's like Denmark and the United States; it's all the same. We can compare the populations and blah blah blah, and that's not true.
One thing that Lone, perhaps we should mention also is that there's a high degree of trust in the authorities, and we saw that during COVID also, that whenever, and that is because you have an discussion in society. We have about 10 political parties in parliament, and during COVID we had a health committee who vetted all our non-pharmaceutical interventions with all parties, even also the parties who was not in government. And that gives you a more, what shall I say, detailed discussion across the aisle. And that builds trust. And that's what you don't see in the US at the moment.
Michael, what do you make of what you're hearing here? Do you think there's a fundamental flaw here in trying to take Denmark's approach and number of vaccines and the way they recommend it and transporting it over to America because we have such vastly different medical systems, populations? I mean, where are you at in terms of what we could have taken from Denmark and what we did take from Denmark?
My view of this is that I feel like the public health community has latched onto this idea that Denmark is it is in a luxurious position to have fewer vaccines because they're more affluent and healthier. Denmark is certainly more affluent and healthier, in general than the US on average. But I'm not convinced that the data shows that there's something markedly different in the healthcare of acute illness due to these vaccine preventable diseases. I think Denmark has a decision-making process that's different than the US. The US is maybe more, I think we're pretty overzealous a little bit on vaccines, particularly our fixation on annual vaccines for certain things. But I don't think I have never seen data that really shows that there's a good argument to be made that Denmark does a better job than the United States at keeping kids alive through an RSV infection. I'll just say that. And I think Denmark probably doesn't see deaths because it's 55 times, the US is 55 times larger than Denmark. And so, of course, we're going to see deaths. If we see 20 to 50 deaths, which is about the number of rotavirus deaths we would see each year before the vaccine, that would statistically mean that Denmark should see 0 or 1. So I think the public health community has latched onto this idea because they're like, especially in the United States, because they're grasping for reasons to say why we shouldn't be adopting Denmark's vaccine schedule. I just think we're different countries. Like we have different policies, we have different decision making. If Denmark has taken a decision for economic or otherwise to not bring certain childhood vaccine schedules in, that's Denmark's decision. The US has taken a different view. I don't believe, like, the US is good at one thing in healthcare. It's not good at primary care, but it's really good at keeping kids alive, when they do show up at like our complex care is really where the US does shine. And so I'm not going to say that there aren't more barriers here, but I just haven't seen the data anywhere to suggest that Denmark truly does do a better job at keeping a kid healthier through an acute respiratory virus. And so I've just seen it everywhere in the news lately. It's kind of like this talking point that everyone's latched onto, but I haven't seen the data. The data doesn't back it up.
Well, what about the data around like just infant mortality rate or childhood mortality rates? Like ours are much higher than in Denmark. That is real data. And but
we have, that's in the context of our childhood vaccine schedule. So I don't know that is being driven by Denmark not having vaccines. You're kind of like pointing in the other direction. My point is, I think if public health is going to latch onto things and really drive these discussion points, like, let's bring data to it. Let's really, if that's actually why Denmark is in such a luxurious position to offer fewer vaccines, then if we're going to say that that's the reason as a public health community, like, we should have data to back it up. And I'm not saying that that's like right or wrong. I'm just saying I am not comfortable with everyone just saying it, and I can't find any data on it. I just think that these are different things. Should we be looking at Denmark?
Yeah, well, luckily we have two people from Denmark right here.
Lona, do you want to respond? Yeah.
I entirely agree with regarding data. Of course, we need data here, but in Denmark, we created data regarding what does a socioeconomic position means to risk of death. And the socioeconomic position means a lot. And the inequality in the United States, as far as I'm concerned, and of course you know your country much better than me, but you have a much larger part of the population with lower socioeconomic position. And I think in such families, I don't know, but how can they go to the doctor with when the child is ill if they cannot pay? So in Denmark, we can see that even in Denmark, where everything is free, we can see that the risk of dying from cancer, you probably know that for childhood cancer, the treatment is entirely protocolized. So there is rules for everything. And if you have a lower socioeconomic position, the risk of dying from cancer in Denmark is double. And if you, for example, have one parent with another ethnical background than Danish, then you have an increased risk of death, childhood death in Denmark. And if you have two, you have an even more increased risk. So socioeconomic position and education means something. And now the risk of vaccine preventable diseases in Denmark, if you, for example, wish to see how much measles or mumps or rubella, how much you bring it down with the jab, it's not possible anymore because we don't see these diseases in Denmark, luckily, anymore. But I acknowledge what you say, Michael, and I think you have a wonderfully good health system for those who can access the healthcare.
Well, let me ask on that, because I think that's a really important point just to move the conversation farther. Now, it sounds to me like the question is, do we need to keep our vaccine schedule a certain way because of a socioeconomic reality in this country? Or do we need to keep it a certain way because of the actual disease burden in this country? Does our socioeconomic condition actually affect the disease burden? Am I asking it? Am I framing it the right way?
I think it's a little bit of both. I guess where I stand for these vaccines, though, is that if it were me, if I were living in Denmark or if I were living in the United States, as an example, I'd want my infant to get the RSV monoclonal, or I'd want my spouse, the mother of my kids, to have been vaccinated during pregnancy to passively pass antibody protection to the baby. I don't really care what country I live in. The burden on that kid if they get RSV is actually quite similar. Now, would I feel even more extreme on that, or more towards the U.S. if I were if I were a lower socioeconomic status than I am? Maybe, but I guess my point is, like, I don't buy it that it's just because Denmark's health system is so much more accessible that Denmark shouldn't be vaccinating for RSV or something, or a rotavirus. Like, I just don't buy that argument. We've latched onto it again without data. I think look it up. The rates of hospitalization are actually the same, and the rates of death are the same from rotavirus in both countries. And so, like, I just think we have to look at each of these vaccine by vaccine. Hepatitis B is a really great example where even in the United States, like we had a whole podcast on this previously, that Hep B is a very risk-based kind of, like, for an infant who doesn't crawl yet, their risk of getting hepatitis B through environmental exposures it's not even across the United States. There are certain populations with much higher hepatitis B, but does that mean that the people with the lowest risk need to get the hepatitis B vaccine at birth? My argument is no. If you know that you're low risk and you have data to back that up based on testing and all sorts of things, then we can make those decisions. And that's an area where I think shared decision making actually does make a lot of sense. Not the way that it's gone with the ACIP decision, but like 24-hour vaccine versus within the first month or two. I think that's different than the RSV vaccine. It's different from the rotavirus vaccine. So we're trying to lump it all together. And I just think that that's like probably foundational to why we're having trouble even having this conversation, because it's why ACIP does exist. They look at each vaccine very, very carefully for all these different pieces. And they don't just say, hey, we're just going to like full bore change everything at once to fit something else. Like that's one thing I'll give ACIP a lot of credit for. Each vaccine has been evaluated very, very carefully for that vaccine and that disease burden. The role of true universal recommendations versus risk-based or versus shared decision-making. Part of that is, what is the true community impact? Measles is the best example, obviously, because of its transmissibility. If you're going to see the impact of one kid not getting a vaccine on the community in terms of reduction in herd immunity and things, then that is like something that ACIP, and I hope, did go into RFK Jr.'s new decision-making thinking to not change MMR, because it would have such an outsized effect on the kids who are choosing, on the whole community. And so that's part of this decision making too, which is like on a vaccine by vaccine basis. If there are vaccines that are really primarily preventing illness in just that child, then maybe those are vaccines that are slightly more appropriate to be in a shared decision making bucket versus vaccines that are preventing disease transmission across the whole community. And again, then the onus is on pediatricians to advocate for their patients to do the best thing for their kids, which is what we do as doctors all the time anyway, or at least should be doing.
We're talking about MMR, which, like you said, hasn't changed, but let's talk about what has changed. And let's talk about what is really driving this change. I think for most people, what has been resonating and what they're hearing is the number of shots. And we're saying we're giving too many shots to our little children. And we've heard them throw out numbers like 72 shots, or the president has said 80 shots. I just want to, and Mike, you can help me out here. Let's just set the record straight on the number of shots that are given.
If we took the vaccine schedule prior to any of the changes that HHS just created, And we were to actually tally up the total number of recommended vaccines that an individual would get between birth and 18 years of life, it actually does come out to about 73 vaccines that you'd get that we have currently available today. Now, around 36 or so of those, or almost 40 of those, are from COVID and flu annual vaccines, which are or were recommended universally starting at 6 months up to 18 years. And so there's a couple things that we can do. We could combine vaccines. There's efforts underway right now for combined COVID flu vaccines.
Yeah, I mean, Mark, you've often talked about how pediatricians around America will often use like a combination version of these vaccines, like a combined version of these vaccines. And the real number of jabs probably would go down to like between 50 and 60. I mean, it's still not low, but it's certainly not the 80 or whatever that the president was saying in babies.
Skilled, you had said that you think that the United States does give a few too many shots, or I forget exactly how you said it, but tell me why you think they're giving too many and what specific ones can you say are too many?
Well, I mentioned the influenza and COVID, and I think it was deliberately decided when I was at State and Serum Institute 25 years ago not to include influenza in the childhood vaccination program because it's not perceived as a problem in the population. And therefore, what we were afraid of at that time was having an annual shot for something people do not think is a problem will decrease the overall adherence. And that's the same attitude we have now with COVID, that we are not recommended it for children.
What we maybe need to discuss is that vaccination program is also an act of solidarity, and I think it's very obvious now. We represent a small collection of probably very highly educated people, and we cannot even really find out what is up and down in how to decide which vaccines is most appropriate for the United States and Denmark, and we can discuss this for hours and hours, and maybe for the rest of our lives, and not entirely agree. So, and then we are back to what you mentioned, Michael, that very transparent and also decided programs may be needed if you wish to have high adherence. And then if you are highly educated in Denmark, you start to get skeptical. Is this really necessary for my child, this jab? And then you back out and you forget your solidarity. Because we need some solidarity with the less educated persons, because they are having the highest risk of severe disease. So I think my children, I have 5 sons, I think that they are, because of many factors, low risk for severe infection. They are very well vaccinated, I can tell you. But I think I need to also have them immunized because I'm part of the Danish society, and we decided this, and we are very as you said, Eskil, we have a lot of trust in our community. So I think it's fair enough. They have to have these jabs because that is what we decided in Denmark. And it's not much shared decision making for each and every jab because there is not time and maybe also not so much reason for that because things are getting too complicated. And if people with low education and not much time and maybe even less time than us to think about vaccines, how should they work this out?
I just want to put one fine point on it. I think we touched on it earlier, but the HHS leadership in making this change, they cite trust and rebuilding trust as a just a running theme throughout their announcements. But when you step back and you look at the narrative out there online, among certain communities, there's just this belief that it's just wrong to give a kid this many shots. That there's something inherently wrong with it. It doesn't feel right. It doesn't pass the smell test. It's unnatural. We didn't used to do it this way. We should sort of a longing to go back to the simpler times when we had many fewer vaccines, many fewer shots. I just want to underline that Denmark, you guys, the ones that we modeled in part these changes, you are saying to us that you don't see anything inherently wrong with the number of shots, the number of vaccines America uses as a matter of health. You're saying for you in your system, you guys land on a different number, a lower number, because you are thinking about things such as trust in the system. Is that right?
Yeah, I think you are absolutely right there. Yeah. That is a good way of formulating it. Absolutely.
I think, having the two of you here is just a great opportunity for us to sort of ask you as to be some consultants for us. And so I want you to be a consultant for the American healthcare system. Here's a question for parents who are listening today. Is my child safer, less safe, or no different because of the changes that were just made? What is your most honest answer that you can give? Who wants to go first?
The child is less safe. I think the primary concern here is the hepatitis B vaccine. I think that's actually a bit concerning that in the United States, where the rates of hepatitis B is much higher than Denmark, and the screening process is not as tight as in Denmark, I think the conversations about hepatitis B may make it, you may see the transmission going up. And that's a lifelong infection. It's not RSV, it's not influenza, it's not pertussis. It's a lifelong infection.
Okay. Eskil?
Well, I would say that you are probably among the top 10 affluent people in the US. So probably it wouldn't make a big difference for your children. But if you take less advantage, affluent people, then it would make quite a big difference. So, and that's what Luna has emphasized several times, that there's a huge difference in the social structure between Denmark and the US. But I still think when taking decisions on the childhood vaccination, this is also a communication issue. So if you cannot communicate the rationale, what is the risk for your child, for other child and other social economic groups, and what is the benefit and what is the side effect to the vaccine, you will lose trust and adherence. And basically, we want to control these infections in our society. And one of the things that I'm worried about is that with these anti-vax, then you will have a slipping adherence to more serious infections like polio and diphtheria, tetanus.
I want to bring Mike in, but I want to add one little addendum to what Mark said, which is like in our country, there's a couple of things happening, right? Which is there's diseases that we have to protect ourselves against, and then there's increasing distrust for vaccines.
Yeah.
And in a sense, the vaccine schedule, my most charitable interpretation of it is, could it in fact bring in people who would otherwise be nervous about taking certain vaccines because you've sort of made it that you don't have to sort of get this very high amount all the time. You don't. And Mike, I basically want to ask you that, which is that, like, yes, answer Mark's question about, do you think that this keeps us safe? But then also the idea of bringing more people into a system, like, could a more flexible schedule ironically bring more people into a system?
Yeah, I think it's the exact conversation that is completely absent from almost every public health communication I've seen. Because so the short answer to Mark's question is, like, for the kids who don't get vaccinated, they are less safe against those diseases, yes. But if we really take a step back and we say, let's not talk about theoretical anymore. Like, let's talk about what is actually happening in the United States, that we've had over 2,000 measles cases and 3 deaths in the past 12 months or so. That's not RFK as health secretary. That has been in the making for a long time now. And I think that this point that you just brought up, Brenda, is like the most important missing piece from the conversation that I hear from public health experts, is that we can't just keep talking about the vaccine schedule as it is, as though people are not already rebelling against it. Like, they are. People are choosing not to get vaccinated, and there's some reason for that. I don't know exactly. I mean, it's a very mixed, there's lots of reasons, but it's been happening at an increasing number and rate for over a decade now. So I agree, like the most charitable type of view that we could maybe take on this is, well, maybe if we require, and I'll use that require word flexibly because they're never required, but if we really strongly recommend certain vaccines and don't as strongly recommend others, maybe the ones that we do strongly recommend, people will actually take more seriously. And I'm really heartened to see that polio and MMR remain on that universal recommendation. That to me, actually, if I were in the camp of not really knowing what to do, and I'm kind of weighing, do I need to get all these vaccines? The average parent like doesn't really know what's what, and is the flu vaccine equal to the MMR vaccine? Well, now this is actually sending a pretty strong signal, especially coming from RFK Jr.'s administration. Get your MMR vaccine. He actually, as the leader of HHS right now, kept that on the schedule for universal recommendation. So my hope is that that might actually be sending a pretty strong signal, ironically, to people who are maybe on the fence about MMR to get MMR. Like we actually just kept it on the schedule. And I think these are levers that are scary to talk about. They're very uncomfortable for us as public health epidemiologists, vaccine epidemiologists to talk about because we have had the luxury from the 40s up until 2000 to really more or less not have to worry about this conversation. But since 2000, we do have to worry about this conversation because there has been this increasing number of people choosing not to be vaccinated. And COVID accelerated that. We mandated COVID vaccines primarily around transmission, they weren't even proven to protect against, and then ultimately proven not to really protect against. And we mandated those vaccines, and that pushed people off of all vaccines, or at least some people. And I think we have to own that. We have to think about ways to mitigate that, and we have to really prioritize, kind of like the administration has done. What do we really want to make sure everyone's universally getting? And then what can there be more flexibility on? Hopefully all the kids will get vaccinated for all of them in the shared decision-making bucket, but maybe, just maybe, this will at least open the conversation for people on the fence to feel more confident about things like MMR and polio and really keep those squashed.
But doesn't that presume that everyone's goal here is to increase or to keep strong our vaccine rate? Isn't that, are you presuming that that's everyone's goal? I mean, I think what you're saying is, from your perspective, you want to keep a high rate of vaccine use, and giving on some of these perhaps smaller ones, letting that move to a category where you really should sit with your doctor and talk about it, that's going to instill trust and bolster the really important ones, right? I mean, that's
Yeah.
a little bit
I
of
think
what we're saying
I think
here.
it could. I mean, I do. And I think that like one problem, or I don't know if it's a problem, but one objective of almost anyone in the vaccine community, at least historically, I would say the kind of the old guard of the vaccine, like the generation of epidemiologists and public health professionals who really ushered in the era of vaccines. It's kind of like, if we're going to put a vaccine out there, we're aiming for elimination. That was kind of that's the traditional aim. Measles, polio, smallpox, that was rubella, the mumps, like we were aiming for elimination. And I think it's okay to have the conversation like, do we truly need to aim for elimination of every disease that we have a vaccine against, or not? Because I think when we try to squeeze every last ounce out of everything by so universally recommending everything, like it does kind of undermine things. Maybe there are some things that we can tolerate, like rotavirus. Is 20 to 50 deaths a year in the United States okay? No. But if it means that it's pushing people away from measles and polio vaccines, like then maybe. It's hard to create these calculations, but I think we have to take in social and behavioral change and response to vaccines and the way we recommend them as just as important a piece of the puzzle as what is the sheer efficacy to prevent that disease. And I just think it's missing a little bit. And so I agree that, like, I don't know that should always be the discussion. I don't know that everyone, like, just vaccine uptake by itself isn't really like, I don't know that it's the only metric we should be looking at overall, because you can get these sort of contradictory effects. If you really push towards vaccine uptake of everything, you might actually paradoxically get a lower rate of the really important ones.
Lona, I'm going to give you the final word. Do you have hope that if there's one upside to this, it might build some trust? Or do you leave this a little more worried?
I think all of us have many reasons to be a bit worried about what is going on in the United States, and to all of us actually, and what is going on in the United States, because you are so influential, is creating insecurity all over the world. That's not only vaccines, but in many things. But now you started this process regarding vaccines in the United States, and you are not making it easy for yourself. Definitely. This discussion will go on for years, and I don't, because you see, I think we know actually that trust or vaccine uptake depends on trust, what we already said. But if you have like a very unstable political situation and polarization within a country, then you have lower vaccine uptake. And you see that in every state with a war or some public insecurity, the vaccine uptake goes down, because vaccines are prescribed by the state. And if there is some kind of distrust between the state and the population, I think it will always affect vaccine uptake. I think Michael is right about maybe you shouldn't drive for elimination of diseases. I think you have to take it all over again. And I don't know whether it's good or bad to start with the Danish vaccination program, but it's very important to look at the severe diseases, that the vaccines targeting deadly diseases. And then I think actually my worst or my largest concern is that this is maybe not so much about vaccine efficacy or health. Actually, it's much more about polarization and political distrust. And that makes me concerned.
Lona, thank you for that. Look, you're going to get no argument from us that there is heavy political polarization and distrust in this country. That's part of what our show is exploring. And on some level, I think from what Mike is saying, you have to sort of look at what this population is. And I don't know that it's only the affluent who distrust vaccines. I'm not sure that that's entirely, that we even know that. I think it's all kinds of people. The truth is, we sort of have to hold all these things to be true. We have to protect against infectious disease, and we have to figure out how to build back trust in these systems. So I want to thank Eskil Peterson, Lona Graf Stensballe, and Michael Mina for joining us on Why Should I Trust You on the special episode. I just want to say my best friend is half Danish, so I get like Danish candy sent to me all the time. It's delicious. You guys really love your gummy candy treats, I've noticed. Man, I'll tell you, there's no war on sugar in Denmark. I'm Brenda Adhikari. He is Tom Johnson. He's Dr. Mark. She is Maggie Bartlett. Huge thanks to our guests. And we will see you right back here next week.